Hi, everyone, and welcome to this quick 30-minute webinar from Metopio and the Michigan Association for Local Public Health. We want to thank Norm Hess for joining us today and helping set up a time slot for Michigan public health leaders that will hopefully be very informative and worthwhile. Also on the call, we have Jeff Monahan, Metopio's Director of Partnerships for the state of Michigan. We have Will Snyder, Metopio's co-founder and CEO, and Heather Blonsky, the Vice President of Data. So we'll start with a quick overview of what Metopio offers local public health departments like all of yours, and then we'll pass it over to Will to dive into some of the specific modules of the platform. So Metopio is a complete data and analytics platform built specifically for public health teams. And at its core, Metopio automates the work that used to take you months, like community health assessments, community health improvement plans, and so on, so that your team can spend less time on data collection and more time on strategy and action. Even beyond CHAWS and CHIPS, the platform brings together everything you need for your public health workflows in one secure place. So that means surveys, qualitative data, outcomes data, programmatic and financial data, you name it. With Metopio, there's no more bouncing between spreadsheets and siloed systems. From there, Metopio can help you tell the story of your data through dashboards and visualizations that are so easy to share with partners, leadership, and even your community through public-facing health atlases. And once your chip is underway, you can use Metopio to track performance and manage quality improvement so the work does not stop when the assessment does. So now that you have an overview of our entire full service community health data platform, I'm going to pass it to Will to go deeper on our specific modules, starting with the CHA automation.
So regarding the community health assessment, the way we like to think about our automation and the selected deployment of AI in the platform is it's really there to support your expertise in your work. And it takes the tedious stuff off of your plate, the initial drafting, sort of the captioning and so forth. But this will help you very quickly move through your data organization, understand the trends, understand what's happening, turn that into actionable insights, identify cross-cutting themes within the data very, very rapidly, and then ultimately get to your final report much, much faster than the old manual way of doing this and kind of piecing everything together. But we always like to remind our users and potential users that AI can be turned off at any point. If it's not something that's allowed by your jurisdiction, it's not something that has to be turned on in the platform. And then when it is turned on, we make sure that there's an audit log, that the evaluation framework is there so that you can fact check anything that is created by AI in the platform. Once you've done your assessment, if you are FAB accredited or thinking about accreditation, you move straight into the community health improvement plan. And again, all of this is seamless and within the platform. So we do more than just the data visualization side. We're really thinking about this complete workflow for you as a public health leader in your state or community, and going straight from that assessment directly into figuring out what you need to do to address the issues and needs that were identified. We have a rather large program library that we've been building and continue to build with Heather's team. You can also design and build your own programs within the platform. And then once you have those programs in place, we can collect data directly into Metopio so that you can build dashboards in real time to see your impact, to understand where things are working, where they might not be working, where you might need to do that quality improvement approach. The great thing too is you can create shared metrics across multiple programs. So if you're thinking about, you want to see A1C reduction across the cohort, but you're running 5 different programs, this chip interface allows you to very easily create a combined metric across multiple programs. And as that data is collected into the platform, these dashboards build in real time. Those again can be shared and pushed out to different audiences. So just jump in and a quick question on the Alchemer survey software. That's fantastic. That's our preferred software integration. We can work with Qualtrics, we can work with SurveyMonkey. We're agnostic, but in terms of what we built into the platform, we work directly with Alchemer. It's sort of a white labeled solution in the platform. So glad to hear that's what is happening in Michigan. So, I've touched on AI kind of as an assistant at the NACCHO conference last week, NACCHO 360. We presented on what we've heard over the last year. So we've done some surveys and focus groups with NACCHO, kind of in partnership to really try to understand, um, what's happening. We heard a lot about shadow AI, that like you might not have an official AI policy, so people are doing stuff on their phone. We've also heard that you might be tied to a single vendor, or you're allowed to use lots of different vendors. The gambit is there. But I think the pieces that we've heard that really kind of roll up into the narrative that we're building for is that overall, public health officials are cautiously optimistic. So it's really this jumping off point, and we're really being able to better discern now where the value is. And a lot of that is in just speed to insight, workflow improvement. But at the end of the day, it should never do the interpretation. And that's where we've seen, false starts with AI and technology over the last year or two, is that when people kind of expect it to do more than it's capable of, or more than it's capable of fact checking, you run into problems. And so we really focus again on the workflow improvements, the assistance piece to really help you get from a question to an answer, and then that answer leads you into the further interpretation and intervention. The other piece too is, or another piece is that trust is really everything, as well it should be. You're working with sensitive data on sensitive topics, and you want to make sure that whatever AI you are using, you can understand what it is and isn't telling you. There's certainly, AI is built, large language models are built on human information and human data. Humans are inherently biased. That bias does come across in models. So you want to be able to make sure that you understand where that is and how it can be fine-tuned or corrected. So we always are making sure that our outputs are sourced and that there is an audit log for any AI that's used in the platform. Kind of back again to that interpretation piece, like this is directly from a number of epidemiologists and program managers around the country. We heard over and over again that people want AI to help them sort through lots and lots of data and to uncover insights, but not to draw conclusions with that, especially given all the sensitivities we have around public health data and the work that's being done. And then ultimately, human control is not negotiable. So the true governance model is critical to a successful use of AI in public health. So the good news is we've been able to take all that feedback and let it drive our product roadmap. So we have created a new data model, like I said, that can handle line level data. But the PHI and sensitive data lives in a completely separate environment, and any AI in the platform never has access directly to that data. It's a non-negotiable from our end that the AI will never ever touch your data or sensitive data. Second, you control how it connects to any data that doesn't meet that sensitivity criteria. And then what we've programmed and built our AI to do is to surface and present, but not interpret without you guiding it. And the way that it does this is through, I'll get in the weeds here a bit, something we call text to SQL. So this takes a plain language command from you or somebody on your team, like which counties or which zip codes in our county have the most diabetes or diagnosed diabetes. And our system the AI is used to convert that plain language into SQL code, which then goes and fetches the data and returns it to you as an insight or visualization. So the AI itself is never actually touching the database. It's merely a step in the process to be able to answer those questions. And then ultimately, you can track every action that AI takes on the platform, so you can trust what you are seeing. So, as we think about this next phase of Metopio, we're really excited to launch some pretty powerful stuff this fall. As I mentioned, performance management, quality improvement is in development and will be out shortly. We're also working on a whole new dashboarding module for data dissemination, which is very exciting. And then Heather's going to touch a little bit on kind of what we call BYOD, bring your own data, which again lets you work with any kind of arbitrary data in the platform and connect that to our vast library of curated data. So I probably should have said this at the beginning, but when you log into Metopio, you have access to billions of data points. So we curate not only federal data sets, so Census, EPA, HUD, CDC, et cetera, but we work very closely with state and local to also bring in additional data. And then we have a number of third-party data partnerships. So we are working with Pophive data lab out of the Yale School of Public Health, which provides access to a lot of surveillance data. So RSV, flu, pneumonia, COVID, lab A1C data, Google search data, wastewater surveillance data. So we have a lot of real-time or near real-time data sources in addition to those more macro data sources from state and federal resources or state and federal sources. In addition to the data collection, curation, and governance, we also have these AI-supported analytics. So thinking again about if it's just a one-off, like I need a PowerPoint presentation about chronic disease in, Walloon Lake, Michigan, like put this together for me in the next 5 minutes. It will help you do that. It will think about your brand colors, your fonts, all that kind of stuff, and you can work with the assistant to build what you need very quickly. Or it could also be, I need a draft of a community health assessment done ASAP. Here's all the data. Help me sort through this and start to put together a Word document. But at any point, you can jump in, edit, and control what's happening. And then again, create those reports, share them publicly, work in months or minutes instead of months, and then get that data out to a broader audience directly through the platform, through our Health Atlas module. So yeah, we have a lot of data, and I've talked a lot about data, but the most fun thing to do with data is to actually analyze and play with it. So with that, I'm going to turn it over to my colleague Heather, who's going to jump in and show you some great insights from around the state of Michigan.
Great, thank you, Will. And I will share my screen. Here we go, and I think we have the link here, if everybody can see this. I'll also put it in the chat. There we go, and this should be public, so everybody can play along at home. We'll keep this open for at least a while, so you can keep looking at it and playing with it later. You can share it widely. But really, I focused on 3 areas here from our quick poll in our reservation program. Poverty, mortality, and access to care. And I will start with poverty here. I just wanted to give you a little tour here of how things work. If you are looking at a data set here, you can always pop that eye up and see where it came from. And this is true all across the Metopio platform. Really just notes about exactly where we got things. There's a link to if you want to go look at the original documentation yourself. But really, we always want to keep that very transparent, where everything came from, where we collected it or calculated it from. But really, this is just your basic poverty level. We went with 200% of the poverty level. That's the federal poverty level. But we do have various other thresholds, the 100%, the 150. And you can see this is both an issue for census tracts inside cities and also in rural areas. So that northern part of the Lower Peninsula, parts of the Upper Peninsula tend to have higher rates of people below that 200% of the poverty level. 34.4% of residents in this tract, which is pretty close to the coast here near Huron National Forest. But really, you can zoom in here on any of this and take a look at where that gets you. I did have a couple other ways to look at poverty, because one way is, of course, that federal poverty level. That doesn't always tell you the whole story. So one of my favorites here is the severe housing cost burden. And I think of this as a poverty measure because it tells you where the cost of housing or the cost of living has outpaced incomes. And so again, we can look at some of the cities. There's Lansing, Flint, of course, Detroit down here. And there are pockets where this is very much true, Ann Arbor also. And so this is the combination of how much income people have, but also how much housing costs. And so it can look a little bit different than that flat rate of poverty. It also tends to be more of that urban poverty. You'll notice that the rural, zoomed way too far out, the more rural areas of the upper part of the Lower Peninsula are not as much affected. That'll be the different housing costs in those areas more than the income levels. But then I have a third way of looking at this that really, I did this at the county level just because this tells you more about how income is distributed. So this is the lowest quintile, so the lowest 20% of earners, and how much of the income, if you added up all the income for that time period, is allocated to that fifth of the people who live in that county. And so if you look at Wayne County here, 2.5% of income is earned by that lowest 20%. So that difference tells you not just that there is a level of poverty, but of the people who are at the bottom of that range, how much money do they actually have compared to the people around them? So this is both a poverty measure, but also a disparities measure. So it tells you a different story about all of these places. Those three together, and we have others, really give you a very nuanced view of what poverty is looking like in the areas that you serve. Now, if we go back to the original here, I wanted to hit on mortality. This was definitely a question that we got in our RSVPs. And there are a couple ways of looking at this. We have life expectancy, but we also have years of potential life lost. And I'll start with life expectancy. One thing I always want to point out is when you look at life expectancy at the census tract level, we only have one data point for that because it was a massive project the CDC did once. And we're hoping they'll do it again, but it is a massive project to get it down to that level. So when you're looking at census tract differences in mortality, you are looking at 2010 to 2015 before COVID. So we don't expect this to be perfectly accurate now, but it does tell you a lot about where things started before COVID hit. And of course, you get a lot of subtlety in here about differences in very small areas, which is fascinating. But again, on the older side. Now, if we go back here and look at years of life lost, that current data is always going to be counties. That's universal. This is how it comes from the CDC. But I rather like years of life lost here for a couple of reasons. One being that it gives you a really convenient way of thinking about this. If you look at Wayne County, that 12,000 life years lost per 100,000, that means of all the people in Wayne County, how many of them live to 75 or later? You don't get any credit for years after 75. This is like premature deaths. How many people don't make it to 75 and how far did they miss by? And so 12,000 life years per 100,000 would be something like either 12% of the people made it to 74 or maybe 1% of the people made it to 65, something in there. And of course, each death counts for a slightly different. But you can see there are some areas where most people really do make it pretty close to 75 or up. So it's just a different look at it. I did leave stratifications on, so you can look at this by race, ethnicity, sex, and age. That age is a little complicated. Of the people of that age who had a death in this time, it tells you something about who has lost years in that age band. It does tell you something about infant mortality. There was actually a little spike in Sheboygan. Now, one of the other things you see from this is as you get closer to 75, there are more deaths. It peaks about 55 to 59, and then it starts going down because those deaths are counting for fewer years. But it's one that you can definitely dig into. It's one of my favorite measures. And so I did do one other look at it, which is the ranking of counties by years of life lost. Wayne County is the highest, Roscommon and Genesee right behind, but also those reasons. And this is the other reason we have county level data, because you can get to that detail, the reason for the death. Cardiovascular disease is by far the highest, cancer, and then accidents is third. This does go on for a few here, but really you could look at each of these separately. COVID, for instance, if you sort by that, still Wayne County at the top, but you start to see a resorting here. Genesee's moved down, just to say how much did COVID contribute to that. So this is one of my favorite measures. It really gets into life expectancy in a kind of concrete way. And then my third set here is access to care. These are some of my favorite measures because they're a little bit complicated, and that's what we do. But we have a drive time to hospitals, and I went with hospitals with obstetrics here. There are hospitals without obstetric care, obviously, but we took the characterization of the hospital from the Medicare cost reports, and then we just calculated from each census tract to that hospital how long it takes to drive. That drive time is distance on the roads and speed limit, so it's an ideal drive time. So if you were up here near Sault Ste. Marie, you're getting 2 hours to get to the place where you're delivering your baby. That's awfully long. But that does tell you there are pockets that have very, very poor access to inpatient obstetric care. There may be other options there, but that is the situation there. You'll notice in cities, you get much less of that. And that is just an urban-rural difference. One last one here. Download speeds. And the reason I count this as access to care is if we were talking about rural health, especially, and we're talking about how to patch in some ability to contact people who might be farther from a resource, might not have access to primary care, might have mobility or transportation issues. One of our easiest ways to do that is telehealth. It is also kind of a poverty measure because remote employment relies on being able to have internet. And there are a couple interesting pockets here, and I just found it fascinating. You have a difference between the upper and lower peninsula, first of all. The upper peninsula maxes out at about 50 megabits per second, where the lower peninsula is rather higher than that. But you have pockets in both where you have very poor broadband. And that's true in some rural areas and some coastal areas, but it's also true in some pockets of urban areas. And that would be areas maybe don't have fiber, maybe don't have a reliable and interested uh, uh, cable provider. There are a lot of things that can lead to this, but it does tell you something about whether you will be able to use telehealth in those situations, whether that's an adequate response to somebody who can't get to an appointment, and really what those obstacles could be. We do have other measures of whether people have broadband subscription. That's actually a census data. This is just the FCC data. This is the data that tells you where actual providers have reported actual speeds. I really like it. It's just a fascinating addition to any plan you have that requires telehealth or anything that you want to characterize in terms of people's access to the internet. That is my set. These are available for everybody to play with. I would be happy to answer questions. Will, did I forget anything?
Well, while folks are formulating a question, do you just want to give a quick glimpse of the BYOD
Yeah,
environment? You have
definitely.
it up.
Let me pop
Just
that
to
up.
again show what's possible when you start to combine the proprietary and primary data that you're collecting at your health department with this large curated data set.
Yes, and this is actually a research project that we have the data from. Part of the interest in this is how to anonymize a very small data set, but part of it is really getting to that insight. Not to say we had 2 cases in one zip code or 4 cases in another zip code, but that we have a ton of cases. This is sudden unexpected infant death in all the zip codes together that are in that top decile, top quintile for poverty. Really characterizing the neighborhood and then getting that insight to say, here's where the cases are, here's where we're making our intervention, and once that intervention is done, do we see that improvement where we hoped we would see it? We have poverty here and also a crosstab here of household crowding along the bottom. So you can see most of the records are in areas that are high incidence of crowding. That's more than 1 person per room. It's a HUD measure, but also very poor access to transportation. That combination together is huge. And so that story here tells you something about the neighborhoods that are hardest hit by this. We also use the same approach to really characterize multiple different strata or stratifications in the data set itself. So these 2 down here take the research data and also the Metopio curated data to say, what can we talk about in that intersection of the 2? But really, where we started was, what do we know just from the research data itself? So it's a fascinating little bit, but really it draws on all of those insights that we've already curated and what we can do with them, how we can bring it into interventions, and then how we can use it to measure the follow-up. So that's my world's fastest take on bring your own data. This can really be built on any data source, and this is where we keep PHI to keep that out of the original set. All right, we have time for questions then?
Ask away.
Oh, there's a question in the Q&A. What does it look like to share Metopio access between health departments for those with collaborative CHA or CHIP, or between different counties?
Yeah, it's a
That
great
goes to
question.
you.
So we actually do quite a bit of work with collaboratives also between usually nonprofit hospitals and health departments. We have what's called RBA or roles-based access in the platform. So if you're in our community health assessment or CHIP modules, you can be part of multiple teams. So you would have a view for your health department, and then you can also join a team that is outside the health department. So it could be the Central Michigan Collaborative, just making up names here. like Central Michigan Collaborative, that's 5 health departments and 20 hospitals, and everybody can pool data as appropriate in that one team, and then you just toggle back within the interface to your specific health department. This works really well, especially again with the hospital health department collaboratives, because oftentimes health or hospitals will have a zip code based service area, and they'll have like 3 zip codes right outside your county line, and they're like, oh, we need data for these 3 zip codes, and as the health department you have a county jurisdiction or city jurisdiction, so it's hard to manage that. So we have ways that you can be part of multiple teams and multiple collaboratives very easily. But great question.
If we don't have any more questions, I just want to say that if your interest is piqued and you'd like to take a deeper dive, I've included a link to my calendar in the chat. I'd be happy to schedule time for a demo to walk you through the platform. And I think the main takeaway today should be that Metopio is purpose-built for public health. We're all-encompassing. We collect data, we analyze data, we disseminate data, and you can track your impact in real time as well. And Will and Heather, if you have anything else to add, Norm, if you have anything else to add, please do. But I want to thank you all for attending.
And please enjoy the link to the data, and please do share it. It's meant to be shared.
No other questions?
Just one quick question on the, or a couple actually. Connect House, yes. So there's a question about most, if not all, health departments work with their local hospitals to conduct trials and chips, and sometimes the LHDs have little say in what can be funded. Is there a way to connect with hospital associations? Yeah, absolutely, be happy to. We have a number of states that we work in where the hospital association or some sort of hospital collaborative is sort of the backbone or the funding organization. So happy to share examples of that. And then regarding what is the pricing model and public dashboards be available in perpetuity? So to the first question, we're actually the preferred vendor for NACHO. So we have NACHO's negotiated bulk pricing for health departments, and we do an equitable pricing model based on a couple of factors, but primarily the population of your jurisdiction. So we want to make sure that small and rural health departments can access all of these tools. And then, if you use Metopio and then decide to stop using Metopio, we will help you export all of the data off of the platform. The public dashboards would go away just with loss of access, but you could download all of those images so they would become static, whether like a Word document or PowerPoint. You would certainly maintain access to them, but the public facing side would not be interactive. But we always like to work with folks to make sure they can maintain access. Any other questions? I don't know if we were able to show our poll results or not, but if not, we can certainly send them as a follow-up. All right, sounds like the majority of our participants are not using a data and analytics platform for public health. So glad to be able to show you what we're doing at Metopio, and hopefully we can find ways to work together. We really appreciate the hard work that you all do and keeping your population safe and healthy. So thank you for that. We hope you have a great rest of your day. Thank you again, Norm.
Yep, and thank you for. I think this is very informative, and it's fascinating to look at those maps. And I will go back and look at the link because I just think that it is. It always gives you a different picture when you're able to visualize maps of places that you're familiar with. So thank you so much. We appreciate your time. Thank you, everybody, and have a great afternoon.
Thank you.